Hello, my dear students. In this discussion, I'll be taking a surgical topic, that is trauma. And we'll be seeing different scenarios in trauma where you'd likely be asked the questions, MCQs, case basis, and we'd see how to find out the clues, extract the clues from the MCQs. So, to start with, you get a trauma patient. The first case we'll be talking about is flail chest. So in flail chest, you would likely be asked that the patient, a young patient with probably a motorcycle crash, a vehicle accident, and the patient would present you with dyspnea. Chief complaint of that patient would be probably be dyspnea, and these patients will have saturation low, that is hypoxia, and they would be having pain over the impact area. So injury to the chest, dyspnea, presence with dyspnea, and pain over that area. And if you just remove the shirt and if you just see that area, there will be paradoxical rib movement, chest wall movement you'll be seeing along with the breathing pattern of the patient. And when you touch the ribs, you will be feeling the crepitus of the ribs. So these are all the clues that you should expect from that patient in flail chest. So if they have to tell you it's a flail chest, they have to give you this kind of scenario. So that's about the flail chest. That's number one. So what you have to do is you have to see if there is any signs of internal bleeding, because any trauma, the other way of directing this question is any trauma, especially it's a blunt trauma to the chest wall, so you could obviously, the organ that can bleed most probably would be any trauma, any blunt trauma, it's again and again spleen, always and always it's going to be spleen. So you have to make sure that you go through a fast ultrasound scan, fast scan, and then you go to a HRCT to make sure that the lungs are not involved. So because patient presents with dyspnea, the lungs are not involved, so there's no piercing over the lungs and collapsed area in the lungs. So you should be able to rule out those. But if they have to tell you it's a flail chest, they have to talk about the paradoxical movement of the chest wall, and then they have to tell you that this patient is, when you examine the patient, you are able to feel the crepitus of the legs, of the ribs. So that's the case one. Number two is pulmonary contusion, the lung contusion. So again, they are going to talk about a trauma patient who again got injury in the chest wall, and this patient is having presenting to you with again dyspnea, and this patient would be hypoxia, and the part of lung which is affected can get atelectasis, or the lung tissue can get bruised, and there is extraordinarily respiratory distress in that patient. So the CT scan would tell you that this patient is having contusion. So they might simply provide you a CT scan, and you will be asked to know that is this patient having contusion or not. There is a way of framing question, but it's not very common in MCQs. And the next thing is tension pneumothorax. So tension pneumothorax, again the patient would get come to you with dyspnea. So if the patient has met with an accident, and the patient is suffering from pneumothorax, the air trap inside the lung is called pneumothorax. So wherever the air trap is there, from that side, the tracheal shift and mediastinal shift is going to happen to the opposites, towards the opposite side. So that's what you will be expected to know in the chest x-ray, or they would be telling you that they have taken a chest x-ray in which there is tracheal deviation away from the site of the injury. In auscultation, they will be probably telling you that that area where there is pneumothorax, you're not able to hear any breath sounds, and then there will be elevated JVP, jugular venous distension, so elevated JVP. So but you have to note two things: decreased breath sounds on the area wherever there is tension pneumothorax, and then tracheal deviation, sometimes mediastinal deviation, that's up as per the amount of air trapping that has occurred. So this is how tension pneumothorax would occur. But if they have to ask about open pneumothorax, the next question is about open pneumothorax. If they have to ask regarding a patient with open pneumothorax, again similar presentation can be asked, but most probably penetrating type of injury, and there will be open sucking chest wound. So every time this patient is taking a breath, there is a sucking sound. His sound can be heard from the patient, so the air entry in that area will be decreased, and then the percussion note in that affected area is going to be increased. So decreased air entry, increased percussion in that affected area with sucking chest wound is suggestive of open pneumothorax. Sucking chest wound will not be seen in tension pneumothorax. So in tension pneumothorax, that amount of air that is trapped is remaining the same. But in open pneumothorax, every time the patients take a deep breath, the air, trapped air keeps on expanding, and it would be pushing the mediastinum and the trachea towards the opposite side, the normal side, more and more. Every time this is happening more and more. So open pneumothorax is really dangerous, and open pneumothorax can make a patient collapse more frequent, more faster than a tension pneumothorax. And then the next case is about massive hemothorax. So when it comes to hemothorax, blood filled in the thoracic cavity, so hemothorax, so again there will be absent breath sounds. The percussion note in that patient is going to be dull. So similar type of presentation can be there. Penetrating wound would be there, same like open pneumothorax. Penetrating wound would be there. The JVP can be elevated, or the JVP can be decreased. That is based on the hypovolemic status of the patient. So if there is concomitant tension pneumothorax along with the what you call massive hemothorax, so massive hemothorax along with concomitant tension pneumothorax, the patient would likely be presenting with elevated JVP. So that is a sign that is telling you that it's not just a hemothorax, there is also a pneumothorax. If the JVP is low, and there is telling you the hemodynamic status of the patient, that this patient is having hypovolemic shock and that is keep on persisting. So that's one thing that's very important. So in a massive hemothorax, you will be given penetrating wound injury, and you will be talked about probably about JVP either elevated or decreased. You would be asked, you would be told that this patient is having dull percussion note, and you would be told that this patient is having absent breath sound. Wherever there is this hemothorax, there is absent breath sounds. So you would be given probably a picture of X-ray, and you would be asked to find out the diagnosis that it's massive hemothorax. So this is very important. So the signs of hypovolemic shock should be identified, because there is bleeding in this patient. So this patient, you should find out the signs of hypovolemic shock. So the BP would be low. This patient would be in tachycardia. There is peripheral vasoconstriction. So as time passes by, more amount of blood is going to get accumulated in the heart, in the lungs, and this patient is definitely going to collapse in a while. So this is very important. So this should be compared with cardiac tamponade. So in cardiac tamponade, again a blunt injury or whatever, there is a injury to the chest wall, and this patient's JVP is again going to be raised. So when it comes to pneumothorax, tension pneumothorax, the JVP will be raised. When it comes to cardiac tamponade, the JVP will be raised, elevated. But when it comes to massive hemothorax, it can be elevated, it can be lowered. So that is very important. And this JVP elevation will be higher on Kussmaul's sign, something called. So this on inspiration, this JVP will be raised more. So in cardiac tamponade, Kussmaul sign will be there. Kussmaul pattern of respiration will be there, and this patient will have silent heart sound. That's called muffled heart sound, because this heart is surrounded by blood. The injured cardiac area, myocardial area, the injured area is going to be filled with pool of blood outside the heart, and you wouldn't be able to auscultate. So the hypotension, low BP, the elevated jugular venous distension, along with this muffled or silent heart sound, is together a triad, and that triad is called Beck's triad. When you are given that Beck's triad in your MCQ, you should be able to find out that it's cardiac tamponade. So that's how the question would be in cardiac tamponade. So then the next thing is aortic injury. So aortic injury means Again, in trauma patients, if you want to know that there is aortic disruption, only two things you should know: that aortic disruption means the patient would bleed a lot, so this patient would quickly go into hypovolemia. That's one of the thing. And the next thing is, in chest x-ray you would be able to see only one consistent finding, that is going to be widened mediastinum. So mediastinal widening, the mediastinal boundary has been widened. So widened mediastinum along with hypovolemia should always and always put you towards thinking of aortic disruption. So that's very important. There is another thing that we can talk about is esophageal trauma. So esophageal trauma is again going very important, but in MCQ pattern it's not much or almost not been asked till now. So esophageal trauma wise, if you have to know the food contents, if there is any penetrating wound and esophagus has been penetrated, so the gas would be forming around the mediastinum. So mediastinitis will be there, and then pus can be formed, so empyema can be there. So empyema and mediastinitis can be there. These are the clinical clues for esophageal trauma. So I hope all the trauma related, chest related topics have been covered in this discussion. So if you have been provided with these clues, please utilize this video, and please do save your time in finding out the diagnosis. I hope this video definitely helps you. Thank you.